Welcome back. Now, you may have to kiss your medical aid tax credits goodbye. Government plans to use these rebates to fund the first phase of the National Health Insurance. And this was contained in the presentation to the National Council of Provinces. But some are questioning the constitutionality of this proposal. There are also concerns over the funding of the scheme and corruption as well as maladministration. So let's get some clarity now from Dr. Nicholas Cripps, the Deputy DG for National Health Insurance. And thank you so much for your time. A very warm good morning to you, Doc. Thanks for joining us. I suppose let's start with what informed this decision that medical aid tax credits will be used to fund the NHI.
Morning, Jamila. Good morning to the viewers. That's been on the cards for the best part of 10 years already, and it's in the bill, so it's nothing new. For those who have actually read the bill, they will have seen that it is covered as one of the options for moving funds. So the point of the exercise really is that if all funds are going to be paid by the National Health Insurance Fund once it's established, then we need to move them from wherever they are at the moment into the administration of the National Health Insurance Fund. And it's a question of sequencing of which of those sources of funding move at what point.
I mean, also with that being said, I'm sure there were concerns raised, Doc, when it comes to the medical tax credits. Let's talk about some of those concerns, perhaps. I'm sure you've also seen or heard of them as you address them in the NCOP around the constitutionality of this.
Yeah, Jamila, look, I think there's lots of opinion and there's lots of people who have different views and different angles. And who disagree with national health insurance and afraid of change and afraid of corruption and afraid of all kinds of things. But I think that what we have tried to explain over the past 20 years and in the period leading up to this through the National Assembly's Portfolio Committee engagements and now into the NCOP is that the current health systems, both that what we see in the public sector and the private sector, are now on a serious spiral of decline, and we are going to get in even bigger trouble than we are now if we don't act. And the challenges we have is that neither of these systems is, the funding of neither of these systems is efficient, it's not effective, and we spend a lot of money considering the poor outcomes that we get. We need to be far more organized and far more operated in a far more cohesive way if we are going to achieve outcomes for everybody in the country. The tax credits are just one method, and this was mooted, in fact, discussed several years ago, that instead of giving a couple of $100 a month to wealthier people, middle class and upper class people, if that money were moved, instead of giving it as a credit, into the public system, we would have additional money to enable the public sector to fix some of the things that are broken at the moment. On the contrary, what we saw last year is an increase in the tax credit to the private sector, or to those of us who participate in the private sector healthcare, while the minister cut the budget in the public sector. That doesn't make sense for a country to operate in that way. So we hope that today we will see a different approach. We should be systematically reducing the tax credits and redirecting that money into the public system.
When we talk about also other concerns, Dr. Crisp, I mean, what is your answer in terms of alleviating any concern around government's capacity to manage this process, but also corruption and maladministration when it comes to these tax credits, amongst other things?
Yeah, well, we should be concerned. Every South African should be very concerned. We have a history in the recent past of abysmal management and very poor record regarding corruption in the public sector. We see huge amounts of fraud in the private sector. They are raised on a weekly basis, and we see patients, doctors, hospitals, all kinds of people being reported, both in the public and the private sector, stealing from the system in one way or another. So we should be worried. We should be very concerned. But it's not unique to the public sector, and it's certainly not something that must prevent us from fixing what is broken at the moment. So we believe that, number one, having many different funding streams and many different ways of delivering healthcare opens us up for a whole range of perverse incentives. And people will abuse those perverse incentives if you allow them to. If you simplify the system and we all benefit from the same benefits, we all know what we are entitled to, the practitioners all know what they can expect and know how they are going to get paid, you already reduce the risk. But you can never get rid of all risks. So you have to manage the risk that you can't design out of the system by flagging the digital systems and by making sure that you follow up immediately when there are challenges that are highlighted when people do behave in a way that one does not expect. And it's those patterns that anybody in any risk management system will be looking out for. So what we need to do is once we have a bill once the bill is an act, we will publish regulations on what we call the governance aspects of the National Health Insurance, and they cover sections 12 to section 30. And that's where we all must engage very proactively with who will be running this fund, how exactly will the board be created, how will the board report to whom, why, and when, what other structures, management committees, and people will be the fit and proper persons that we will trust as citizens to run our system. So that is where the rubber hits the road, as we say. But I would not disagree with anybody who says that we should be concerned and we should be very vigilant. What I will disagree with is that we shouldn't fix the current systems. We have to fix both the public and the private systems, and we need the resources that are available across the country if we are going to run a proper health system in this country.
Yeah, and I'm sure you would agree that the transition to NHI is going to be quite a journey, Dr. Crisp. In terms of expectations about when it will be then implemented, do you have any timelines in place?
So the bill gives us some insights into that of what's expected from us as the officials to run it. And it's in this section that deals with the transitional provisions, it gives us two phases. Phase one starting this year, once we have some legislation that we can work with, until 2026. And it's expected in that period that we will put the administration in place. It will take a good 9 to 12 months to get the board and the board committees in place and to get them to start to appoint a CEO and start to set up an administration. Then getting those administrative units to function as a public entity rather than as a public service department, such as we do at the moment, will also take time. The bill then allows in phase two for the shifting of the money. So we only anticipate real shifting of money to start in 2028, which is where phase two is described in the bill. So 2026, sorry. So between 2026 and 2028 is the anticipated period for the starting of the moving of the money. But one can anticipate that the changes in the way funds flow and the system is set up will take far longer than that. And we all know that there will be a continuation into the fine-tuning of the way in which the medical schemes operate, the way in which the public sector systems operate, the centralization of the national central hospitals and so forth. These things will take time. We know from other countries that this journey is long. They all talk about anything upwards of 12 years, and many talk about 15 to 20 years. But you have to get, the first 3 years are critical to make sure that we start to get a real functional administration in place. Right now, we don't have that. We don't have a bank account. We don't have any money. We've got a handful of officials who are trying to design the future.
You mentioned medical aids there, and you just brought, to my memory the function of medical aids within the NHI. So, Dr. Crisp, are you saying that medical aids will still be able to offer some services? However, if they continue to run in their current form, when the NHI has been implemented, it'll defeat the purpose of the new system with which the NHI has proposed?
Yes, exactly. So what happens is that if you allow 2 or 3 or more completely parallel systems all providing exactly the same set of benefits and you regard healthcare as a free market competitive environment, we will never get the equity that we need, and we will never get to a position where people who don't have money get healthcare. And the basic tenet of what we're trying to achieve is that you don't get healthcare based on your wealth or your income or your rurality or your gender or your age. You get healthcare because at that point your health needs this kind of intervention. So you get the healthcare that you need, when you need it, where you need it. And the trick is to do it without financial hardship at the time that you need it. And at the moment, both the public and the private sectors don't do that well. In fact, they do it extremely poorly. So the intention is during the transitional period, the shape and form of medical schemes and the benefits that they cover are likely to change. We've seen some of the indication of what's anticipated in that in the health market inquiry. We know that we need to regulate prices, and we are working with the Competition Commission and the Council for Medical Schemes on exactly how we can legally do that and constitutionally do that. That must happen, irrespective of the transition into the national health insurance. But by the time we get to an efficient administration with clear benefits that the state is able to provide, then the private medical funding systems, medical schemes in other words, should not be paying for those same services. That's different from the provider environment. The National Health Insurance Bill is very clear that the private providers are an essential part of the service delivery platform that will be paid for from the fund. So it's a change in the funding structure. And instead of being paid by 71 medical schemes on 308 different options, the intention is that the vast bulk of the healthcare for all of us will be on one benefit from one scheme, that we all clear what we are going to get. Whatever is outside of that benefit package will be for the private market and for the medical schemes. It'll be a long time getting to whatever that's going to look like in the future.
Absolutely, a journey indeed that will take place as we transition to the NHI. But thank you so much, Dr. Nicholas Crisp. A pleasure talking to you right here on Newsly. Give us some clarity with regards to medical tax credits now to be scrapped, of course, all to fund the NHI.